Roger Green, host of the Surfing the NASH Tsunami podcast. This weekend, we are offering 5 conversations from episode 18, our discussion with endocrinologist Cyrielle Caussy about intersections between hepatology and endocrinology. Plus, from the vault, conversation 49.3 from season 2, one of our first conversations about interaction with our endocrinologist friend, Ken Cusi. This conversation focuses mostly on taking a patient-centric view of the relationship between the various metabolic diseases, stemming from Louise Campbell's question about how endocrinology patients, most of whom live with type 2 diabetes and or obesity, respond when provided information about their liver status. Endocrinologist guest Cyrielle Caussy responds with a story about a particular patient of hers who lost weight after receiving feedback, and the group agrees that many patients respond well to this kind of information. The second patient-centric theme stems from Cyrielle's presentation at Paris NASH 2022, when she focused on Swedish work on the 5 clusters of diabetes and the varying relationship between cluster type and propensity for liver and other diseases. In the end, Cyrielle notes, the same factors that lead us to classify patients based on their propensity to develop NASH also describe the prognosis for their diabetes. The final part of this discussion features Jörn Schattenberg reflecting on the mechanisms and relationships that tie diabetes, liver disease, fibrogenesis, and other metabolic issues affecting kidney and heart together. It's an interesting perspective to listen to, as is most of what Jörn says, if not all. In an episode some 2 years ago, Jeff Lazarus made the statement, and I quote, "Hepatology cannot go it alone," end of quote. Since then, everything we've learned about the interplay of fatty liver and other metabolic diseases suggests that no specialty can go it alone, given the interplay of organ diseases and the ever-deepening challenges of poor diet and others related to social determinants of health. This episode is just one direction we should all expect to see more of going forward about working together. So just sit back, listen, enjoy, learn, and when you're done, join the dialogue in our LinkedIn discussion group.
Louise Campbell.
Can I ask how the patients respond from an endocrinology department when they're told that they've got a liver health condition, excess fat or some fibrosis? Because some patients that I come across in different diseases go, don't tell me I've got something else wrong, because they're medicalized, so they're in that medical pathway. Whereas what I see in lifestyle is the opposite. Well, why wouldn't I want to know? Because it's something I can do, and it's something I can do something about. In relation to FibroScan seems to, in my experience, engage people's focus a little bit more. And have you ever looked at the comparison of who changes weight or HbA1c in the group that have been versus the group that have not been fibroscanned?
Cyrielle Caussy.
Well, we did not look at it in a clinical research setting when we compare groups. So I can only share my clinical experience. And there is some people, I was actually one time very surprised. We have a patient, she has obesity, and we were, and probably also type 2 diabetes, but I think our major problem is she has severe obesity and she was struggling to lose weight, even though she has met several times the dietitian. She had lifetime counseling, and it was challenging for her to engage and to actually, apply this recommendation. And one day she comes for a checkup, and we say, we need to check on the liver. It's recommended. So she had a liver stiffness assessment. It was not very elevated, but just in the middle between 7 and 8. So she started to be worried. We use a color code when they put the threshold 8 kilopascal. You need to be seen by a specialist and an hepatologist between 7 and 8. We need to check a little bit next year to make sure that it doesn't progress. And it's very visual. So she actually saw that she was in the orange area where she could move to the red one in the future if she doesn't change her lifestyle. And the next time I saw her, she had lost weight, and she really focused on getting the liver health improve. And this has been something that acts like a motivational lever for her. And it's a good thing. I mean, she couldn't find a motivation to lose weight just to lose weight, but being convinced that it would improve her health status regarding the liver was a very good thing. So it doesn't work for everyone that way, for sure. And there's other people that may not find the benefit, but for some, it can be really engaging and really helpful to actually change the lifestyle and lose weight. And so that's the good part. And most of the time, when we talk about checking for the liver and performing a liver stiffness assessment, the patient are willing to do it. They want to know. And the good thing also is that most of the time we can reassure them, because the expected prevalence and the proportion of patients that actually does have elevated liver stiffness is not that high. So based on my experience, I would say that the majority of them, 60-65% of them, we can just say everything is okay, the liver stiffness is low, and that's fine. So it's not adding so much burden on our side. I mean, sometimes, people must be worried. I will do a liver stiffness assessment, but then I don't feel comfortable, talking about the results. So that's really important as well. Try to understand what are the thresholds, what can I tell to the patient, and most of the time it's not that hard because you can actually reassure your patient that was probably worried to see the elevated liver enzyme or knowing that he has fatty liver. So when you can reassure them that it's not an advanced disease and there is time to improve, it's also a very positive message.
Jörn Schattenberg.
That type of biofeedback, and I think, Louise, you've mentioned that numerous times also in this podcast and offline. I think it also works for my patients. It's very visual.
Can I just take you slightly in a different direction, Cyrielle? Yes, I met you in Barcelona, but I listened to the virtual presentation you did in Paris NASH, and I was really, really interested in the chronic kidney association with I think it was 5 phenotypes, 2 of which you detailed were directly related to NAFLD and NASH. And you've obviously done some work on FibroScan in chronic kidney disease and that association that FibroScan can predict chronic kidney disease to some extent in the diabetics from recollection. But that really, really fascinated me. If we can start to select chronic kidney patients who are at higher risk because of their phenotype, I thought that was such an exciting presentation.
Well, thank you. Yeah, actually, it's so the work is from, the large Swedish cohort where they were able to classify the patient. The idea is that basically in your mind you have the type 1 diabetes, the type 2, and a few of them that late on stage diabetes, which is also autoimmune with antibodies. But you clearly see that among the type 2 diabetes, it's so vast and there's so many patients with a lot of heterogeneity. They were able to classify them into 5 different clusters. And what is really interesting is this cluster is made right at the diagnosis of the diabetes. So at the moment you diagnose the disease, the patient may have different cluster based on insulin resistance, based on the BMI, and based on the presence potentially of NAFLD. And the prognosis is different. So this is actually very interesting to see that, as you said, there is a specific cluster, the third, that's SIRD, which is associated with higher progression rates toward chronic kidney disease and also toward cardiovascular disease, actually. So this is a very, very specific population that you can catch very early on, and you can predict whether they have a higher risk of progression. So I think this is also something that probably doesn't really put a lot of interest in the side of the hepatologist, but in the side of metabolic disease and diabetologists, it's something that we are really interested in, knowing which one of our patients may progress, which one may be at higher risk of diabetes complication. And so that's really informative as well. It could advocate as well to check for the liver status, because classifying your patient based on the presence of NAFLD or not is also classifying your patient regarding the prognosis of diabetes and not only the prognosis of liver. So it's really something that is very fascinating. I think there's more and more work to do regarding the interaction between the liver and the kidney. Probably there's a pathophysiological pathway regarding the fibrosis that you can find in the kidney and the liver that is at stake there. And I think there's more and more discovery to do on that side in specific population with kidney disease and the liver disease.
Let me add 2 thoughts to that, because I think it's very interesting what Cyrielle mentioned, and I'll hand it back to you, Roger, is one, you can argue this is just all coexistence of diseases, right? And over time, the metabolic risk factors adds up. But I think we're seeing patterns where, we get certain mediators that are activated in the liver add to the vasculature injury that's important for the heart, but also the kidney, and that adds to that phenotype, a certain immune activation in the inflamed liver that does have outside effects. And even collagens as a signal that are produced in the liver through stellate cells could have an impact here. So I'm very closely with Cyrielle here that I think through the staging of liver disease and let's say the immune activation, the fibrogenesis that's happening, the outside organ injury is independently of just the metabolic drive that injures those kidneys in parallel. It's probably an augmentation that we see and we're learning here through the cohorts that are being established.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put them in the review section of the page from which you downloaded this conversation, or send an email to questions@surfingnash.com. Next week, while we are spoiled for choice, we have not decided exactly what topic to cover next week, but I promise you it'll be a good one. So until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.